So a slightly different approach than Annie just discussed involves an assessment called BCATS, Brief Cognitive Assessment Tool. And deficits in cognition have been found to contribute to barriers for individuals with schizophrenia, increasing their functioning. So in other words, their difficulties in cognition keep them kind of stuck in whatever barriers of schizophrenia are affecting them. So those barriers, one of the main areas identified is that it keeps them from gaining employment, and so much comes with employment: independence, self-esteem, building connections, friendships. So some of the deficits that have been identified in cognition within this population are verbal memory, attention, executive functioning, among others. And people are finding, specifically psychosocial and cognitive rehabilitation researchers are finding non-pharmacological approaches to addressing these deficits. In other words, they're finding therapies to help individuals overcome those deficits. And clinicians need a better way to assess those barriers that these individuals are experiencing. The BCATS is one type of assessment that can help clinicians in this area. Just a brief overview, it's short, it takes an average of 10 minutes to complete. It's made for clinicians. It's valid. It correlates highly with the gold standard of NCCB, which takes about 60 to 70 minutes to complete. It does show good reliability and small practice effects. I was unable to find an image of the assessment because it appears that it's a more hands-on assessment. For example, you're going to be asking the individual to be interacting possibly with a grooved pegboard, visual reproductions, or do some finger tapping, which would measure various cognitive abilities. Limitations for this assessment include clinicians would need to be trained, as well as materials would need to be purchased in order to administer the assessment.
Do you ever hear things that other people can't hear, or see things other people can't see?
No, of course. Everybody hears the lights talking to you. I don't know what you're talking about. Like, everybody hears it. Sometimes it's a whisper for some people, sometimes it's a yell. And if you want to not pay attention to what the lights are saying to you, then I don't know what's wrong with you, but everybody can hear it.
Everybody can hear it?
Everybody can.
What's it sound like to you?
It just sounds like a robot talking. It sounds like, we need to know this information. We need to... What are you doing?
Oh, just making some notes. Just making some weird progress notes. Does it worry you?
Yes. Where are your notes going to go?
They get, this chart will get locked in the chart room down the hall.
Who has access to the chart room?
Mostly everybody that works here.
Can I get a copy of your notes after you're done?
Does it worry you that there's notes?
Yes, because I might trust you, and I don't know if I do yet, but I don't trust the other people who work here because I don't know if they're working for the government, which they probably are working for the government. So they could actually have access to all of my notes and the things that you're writing down, which I don't know what they are because you're not going to give me a copy of it yet. And I just don't trust that they can actually get that information, and because they're going to use it to their advantage, and they're going to give it to the government, which I can't have that happen. So could you please not take notes?
I cannot take notes.
Why I thought it was important to include this approach is clinicians may feel as though there's not much they can do to help patients with chronic schizophrenia, and that supported talk therapy has been shown to be unsuccessful with this population. Although new studies show that early interventions addressing cognitive deficits reduced negative symptoms and increased cognitive performance. The other area identified as a barrier for this population is in motivation. So the lack of motivation may stem from a learned helplessness that is perpetuated by clinicians understanding that traditional therapies are unsuccessful. So I'm suggesting that if they knew of interventions that were successful, they may be more open to using them. So this assessment, specifically the BCATS assessment, appears to help clinicians address barriers that may be inhibiting motivation in individuals with schizophrenia.
When using assessment tools, it is important to identify any issues the tool may have across multiple cultures. One study looked at cross-cultural validity in the positive and negative syndrome scale across 6 geocultural regions. The 6 regions included Eastern Asia, India, Northern Europe, Russia/Ukraine, Southern Europe, and United States. The results from this study found that there was differences in response to multiple items on the scale. For example, when scoring positive subscale, excitement was found to be one of the most difficult for the majority of regions to score. The most difficult negative subscale item to score for all regions when scoring was stereotyped thinking. India showed the most difficulty, while Northern Europe and the United States had the least difficulty out of all 6 regions. When scoring for general psychopathology, the hardest item to score for all regions was tension. In conclusion, these significant differences in response may be due to errors in the translation between the original and translated version of the assessment, cultural differences, and interpretation of each item on the scale. Being able to identify the items on the assessment that are problematic for different cultures can help the clinician tailor the assessment based on cultural considerations and differences. The DSM emphasizes the importance of cultural and socio-economic factors when working with schizophrenic patients. It's especially important if the clinician-patient do not share the same cultural beliefs. To a clinician, something that may appear to be a delusion but is considered normal in one's culture. An example of this could be hearing God's voice. To some cultures, this is an acceptable and normal part of religion, while the clinician may feel this could be an auditory hallucination. Assessing disorganized speech can be difficult due to the fact that all people across cultures have different variations in the way we speak, including different languages, dialects, and narrative styles. When assessing affect, it again requires the knowledge and sensitivity necessary to differentiate between cultural differences in emotional expression such as eye contact and body language. In the United States and Western Europe, eye contact can be seen as being engaged in the conversation and being polite. In parts of the Middle East and Muslim culture, there are rules regarding eye contact between sexes. Western Muslim women may not follow any of these rules. In Asia, Latin America, Africa, and other places, there are other cultural rules regarding appropriate eye contact. Avulation is a negative symptom of schizophrenia, an overlapping symptom of alogia, which is when someone has difficulty speaking or carrying on a conversation. People may have trouble forming their thoughts or following the conversation. These symptoms can be mistaken due to a language barrier. It is important to note when assessing a patient who does not speak the same language as the clinician. There could be a language barrier that is stopping the patient from participating in the conversation. The patient may simply not understand what the clinician is saying due to the fact that the language they are being spoken to is not their primary language. These are all factors that need to be considered when assessing a patient for schizophrenia.